Anemia in pregnancy. Anemia is one of the common conditions which seen in the pregnant woman, especially in developing countries like India. Anemia is classified into physiological and pathological. You may be knowing about the physiological anemia because during the pregnancy the blood volume is increased to 50% and but the RBC count will be increased only to 20 to 30%. That is a disproportion between the blood volume and RBC increase. So it will lead to a hemodilution, and this is known as a physiological. As this anemia is because of a physiological process, we call it as a physiological anemia. It is mainly because of the disproportionate increase in the blood volume and the HB level during pregnancy. Second type of anemia is a pathological. Pathological, surely it is because of any factors like deficiency of iron, folic acid, vitamin B12. Nutrition anemia is often associated with protein and folic acid deficiency. Hemorrhagic like antepartum hemorrhage or hookworm infestation. Hereditary like thalassemia, sickle cell anemia, hemolytic anemia. Bone marrow insufficiency like aplastic anemia. Definition of anemia during pregnancy. The hemoglobin below 11 gram per deciliter in the first and third trimester and below 10.5 gram deciliter in second trimester. Because of the low HB among the Indian women, HB percentage is 9 gram percentage is taken as for the lower limit for the normal in India. The incidence. Anemia may affect 10% of pregnancies in developed countries and considerably commoner in developing countries where it is a major source of maternal morbidity and contribute to the mortality. Up to 56% of all women living in developing countries are anemic. That means HB less than 11 gram per deciliter due to worm infestation. The concept of physiological anemia, it is, as I told you earlier, it is because of the disproportionate increase in the plasma volume, RBC volume and hemoglobin mass during pregnancy. Marked demand of the extra iron during pregnancy, especially in second trimester. Significance of hypervolemia. You may have a question why there is a disproportionate increase or why only the blood volume is increasing 50% or not the hematocrit. The significance include to meet the demands of enlarged uterus with its greatly hypertrophied vascular system and to protect the mother and in turn the fetus against the deleterious effect of impaired venous return in the supine and erect position and to safeguard the mother against the adverse effect of blood loss associated with the puerperium or during the delivery. Normal hemoglobin by gestational age in pregnant women taking iron supplement by 12 weeks 12.2, 24 weeks 11.6, at 40 weeks it comes nearly 12.6. Criteria for a physiological anemia. HB should be at least 10 gram percentage, RBC is 3.2 million per millimeter cubic, PCV is 30%, peripheral smear showing normal morphology of RBC with central pallor. Most common cause of anemia, iron loss. Iron loss can be through sweat, repeated pregnancy, hookworm infestation and malaria. Then faulty absorption mechanism due to high incidence of intestinal infestation, deficiency, rich carbohydrate and high phosphate reduced absorption of iron. Then faulty diet habit or nutrition deficiency. This is the most common cause. The normal diet of a pregnant woman should contain at least 20 to 30 milligram of iron, of which 10% only will get absorbed in the GI tract. It is often associated with iron and folic acid. The factors lead to anemia include increased the iron demand, diminished intake of iron, disturbed metabolism, pre-pregnancy health status, excess demand as in multiple pregnancy. Iron deficiency, the first one is iron deficiency anemia. The causes include nutrition deficiency, often associated with the protein and folic acid. Iron deficiency anemia, we may think that if you take iron tablet, our HB will increase. But that is not always true. Along with the iron, we have to take the protein also, because hemoglobin have a heme and globin part. The globin part is filled by a protein. So of course we have to take a protein. If we take only an iron tablet, sometimes our HB may not increase. Then infections like chronic malaria, urinary tract infections and TB, blood loss because of abortions, APH, PPH, multiplicity and multiple pregnancy. Iron deficiency anemia, the symptoms include lassitude, weakness, anorexia, palpitation and dyspnea. The signs include pallor, glossitis, soft systolic murmur in the mitral area due to physiological mitral incompetence, pitting edema and cardiac failure in the severe form. Degree is mild 8 to 10 gram percentage, moderate 7 to 8 gram percentage, and severe is less than 7 gram percentage. This is the pallor which we can see in the fingers. Conjunctival pallor is the classical sign of anemia. Then cholinergia is a spoon-shaped nails found in iron deficiency anemia. The interpretation of plasma iron, total iron binding capacity and ferritin. In iron deficiency anemia, the iron and total iron content will be decreased, but total iron binding capacity is increased and ferritin will be decreased. Diagnosis. The woman complains of dyspnea, palpitation, edema of the feet in severe anemia. Pallor noticed in conjunctiva, tongue and lips. Spoon-shaped nails are evident. Pitting edema, soft systolic murmur in the mitral area. Investigations. HP is less than 9 gram percentage. Anemia is described as mild if it is up to 8 gram percentage, moderate between 6 to 8, and severe is below 6. Blood film shows microcytic hyperchromic RBC. The cells are unequal in size and staining. Reticulocyte count also is elevated. Then packed cell volume, mean corpuscular volume, and HP are low. Serum iron is below 60 microgram percentage and iron binding capacity is elevated to 400. Stool examination for the hookworm and ova and urine examination for infection are required. Normal iron requirement. Iron requirement in a normal pregnancy is iron gram. That is 200 mg is excreted, 300 mg transferred to the fetus, 500 mg needed for the mother. This demand is required after 20th weeks and not normally met with diet. Total volume of RBC include 400 ml. 1 ml of RBC contain 1.1 mg of iron. So 450 ml into 1.1 is equal to 500 mg. Daily average is 6 to 7 mg per day. During the last half of pregnancy, the iron is transferred to the fetus and stored in the fetal liver. This store lasts for 3 to 6 months. Treatment. Prophylaxis. The increased demand of iron. This demand is not met with diet after 20 weeks of gestation age, so routine iron supplementation is required. Ferrous sulfate 200 mg tablets provide 60 mg of elemental iron, and 2 tablets per day after meals is adequate to maintain the HB level. Then second is therapeutic. The modern dose of iron therapy depends upon severity of anemia, gestation age, and tolerance of oral iron. Oral iron given in the mild anemia and protein in the diet should be increased. Parenteral oral iron given in case of oral iron is not tolerated, severe anemia, patient near term. Parenteral iron given IM or IV daily or alternative days in divided dose. The total dose is calculated as HB deficient in percentage into weight of the woman in pounds into 0.3. The test dose should be given to find out if the woman is sensitive or not. Next is the blood transfusion. If the woman is severely anemic and patient is in cardiac failure. During labor, the methogen should be given to reduce the third stage bleeding. Prophylactic antibiotics in puerperium is reduced infection. Anti-anemic drug treatment should continue during the puerperium. Food which are rich in iron, dietary prescriptions like liver, red meat, egg, green vegetables, green peas, figs, beans, wall wheat, green plantains, jaggery, dry fruits, banana and apple. Tea and milk should not be consumed within 1 hour of iron intake as it will interfere with the absorption of iron. Second type of anemia is megaloblastic anemia due to impaired DNA synthesis, derangement in the red cell maturation. It may be due to deficiency of vitamin B12 or folic acid or both. Megaloblastic anemia in pregnancy is almost always due to deficiency of folic acid. In multiple pregnancy, as the demand is small. In epileptic woman who is on dilangin sodium, phenobarbital and primidine, these drugs block folic acid metabolism. Chronic malaria and hemoglobinopathies. Vitamin B12 deficiency is rare in pregnancy because its need is less and in amount, and the amount is met with any diet that contains animal products. Signs and symptoms. The insidious onset mostly in the last trimester, anorexia and occasional diarrhea and vomiting, retinal hemorrhage due to platelet deficiency, fever, loss of weight, edema of the feet, hypertension and albuminuria may occur, and this stimulates PIH but fails to respond to the drugs unless anemia is corrected. Woman is anemic but fails to respond to iron. Pallor of varying degree, ulceration in mouth and tongue, hemorrhagic patches under the skin and conjunctiva. Angular cheilosis, ulceration on the side of the mouth in iron deficiency anemia, and also a feature of vitamin B12 deficiency. Blood value shows Hb less than 10 gram, hypersegmentation of neutrophils, megaloblast, MCV is more than 100 micrometers per increased megaloblast, and giant polymorphs are present in the blood smear. MCH serum iron is normal or high total iron binding capacity. Serum folate level is below 2. Folic acid deficiency can cause neural tube defect in the fetus, cleft lip and palate, apraxia placenta and preterm labor. Treatment. Prophylactic. All women of reproductive age should be given 400 microgram of folic acid. Curative. Daily administration of folic acid of 4 milligram oral at least 4 weeks following the delivery. These are the some of the change signs and symptoms which occur in an anemic patient. Folic acid in pregnancy. Prophylactic folic acid deficiency in preconception period believed to cause CNS deformities in the fetus, especially anencephaly spina bifida. Preconception administration of folic acid 5 mg up to 12 weeks of pregnancy has reduced the parental mortality due to CNS deformities. Epileptic women on drugs. These drugs are antimetabolites and interfere with folic acid metabolism. Folic acid routinely recommended in these women to avoid fetal malformation. Then multiple pregnancy. Megaloblastic anemia is due to folic acid deficiency, often dimorphic anemia, both due to iron as well as folic acid deficiencies in nutrition anemia. It is necessary to correct the anemia with both iron and folic acid supplement. Those who take prophylactic anti-malarial drugs as Proguanil need folic acid supplementation. This precaution is not necessary if the woman is take chloroquine. Sickle cell anemia and thalassemia need supplementation throughout the pregnancy. Complication of severe anemia during pregnancy, preeclampsia, recurrent infections, heart failure, preterm labor. During labor, uterine inertia, postpartum hemorrhage, cardiac failure, shock. Puerperium, puerperal sepsis, subinvolution, failing lactation, puerperal venous thrombosis, pulmonary embolism. And risk periods at about 30 to 32 weeks of gestation and during labor and immediately following the delivery. These are any time in puerperium, especially 7 to 10 days following delivery due to pulmonary. These are the risk period for an anemic patient. At 30 to 32 weeks, Y means that time the cardiac output reaches the maximum. A normal heart will, and in these patients, the cardiac output will be more because the heart has to work more and more to meet the as a compensatory mechanism. The complications for the baby include low birth weight and intrauterine death. The first stage management include the patient should be on the bed and should lie in the position comfortable for her, preferably in the left lateral. Arrangement for oxygen inhalation, strict asepsis. Second stage asepsis is maintained prophylactic glove forceps or vacuum delivery done to shorten the second stage. Dexamethasone given after delivery of anteater shoulder. Third stage, careful monitoring of the patient in the second stage of labor. Iron supplements should be continued during the puerperium. Patients should be warned the danger of recurrent subsequent pregnancy.